I'm Denise Anthony. I'm Associate Professor and Chair in the Sociology Department, and I want to thank the Rockefeller Center for Public Policy, in cooperation with Sociology today for bringing in our speaker, Dr. Nicholas Christakis. Dr. Christakis is Professor of Sociology at Harvard University. He's also Professor of Medical Sociology at the Harvard Medical School, and he is an attending physician in the Department of Medicine at Mount Auburn Hospital. Dr. Christakis is a doctor of internal medicine and a sociologist. His unique perspective as both clinician and social scientist is shown in his research on the social factors that affect health, healthcare, and longevity. Evidence of his diverse approach can be found in the scores of his publications that are published in both top medical journals and also top social science journals. In his book, Death Foretold, Prophecy and Prognosis in Medical Care, Dr. Christakis examines the accuracy and role of prognosis in medicine, and in particular in end-of-life care. More recently, Dr. Christakis has been exploring social networks in health, more specifically how ill health, disability, health behaviors, which we're going to hear about today, health care, and even death in one person can influence the same phenomena among members of that person's social network. For example, he has explored in the past how ill health or death of a spouse can have cascading effects for the other spouse. So in another work that we're going to hear about today, Dr. Christakis is exploring the dynamics of health and social and health behaviors in social networks. So join me in welcoming Dr. Nicholas Christakis.
Thanks, Denise. Okay, so we're okay? Yep. So given the size of this audience and the kind of informality to which I'm accustomed, I'm happy to pause or take questions at any time. Thank you, Denise, for the introduction. So I also want to acknowledge my collaborator, James Fowler, on this work. Today I'm going to be discussing some of our current work on the spread of health behaviors within social networks. But as Denise already mentioned, what we're interested in is something quite broader than that. We're interested in how it might be that illness or death or healthcare use or disability or health behaviors in one person might spread and cause all those same outcomes in other people to whom they're connected. We're interested in taking seriously the contention that people are embedded in social networks of a substantial complexity, trying to disentangle that complexity, understand what it means, and trying to articulate a kind of non-biological spread of disease, a kind of sociological spread of disease, whereby things might spread from person to person, but not via the kind of customary mechanisms with which we're usually accustomed, whether it's a spread of germs or a spread of secondhand smoke or the kind of biological or physical means with which we are usually wont to think about these kinds of things. Now, I'm going to start with some work that we've done on obesity, which we've published more recently, but I'm also going to speak a little bit about smoking and eating behaviors, and then actually talk a little bit about the spread of happiness within social networks. To what extent is it the case that your happiness depends upon the happiness of the people around you? How might it be that there could be ripples of happiness through the kind of fabric of social networks that you might imagine? Now, as most of you probably know, the prevalence of obesity has increased dramatically in the last 10 years. From about 20 to 30% of Americans are now properly obese, and about 2/3, 66% of Americans are properly overweight by conventional clinical standards. And numerous explanations for this epidemic have been advanced, including the change in the way we design our cities, to the way we market foodstuffs, which either increase the amount of food we take in or decrease the amount of calories that we burn. But it has become, in fact, trendy to speak of the obesity epidemic. And all this use of this sort of metaphorical expression led me and James Fowler to begin to wonder whether it was possible to imagine that obesity was truly epidemic literally in the sense of spreading from person to person. And so that's what prompted us to try to design the kind of study I'm about to show you, to find a source of data that we could examine, and then analyze it with a variety of methods that give us great confidence that it is the case that weight gain in one person actually spreads to cause weight gain in other people to whom they are connected. Because to the extent that obesity is a product of personal choices and voluntary behaviors, the fact that people are embedded in social networks and are influenced by the appearance and behaviors of other people who surround them, means that the weight gain in one individual should in fact influence weight gain in others. Now, some of you may have seen the press coverage of this article when it came out in August or July this past summer. Did some of you see this? It was amazing. I mean, a lot of the headlines were completely misdirected. They said, you know, ditch your fat friends, which is not at all what we were saying, nor what we think should be done. And it was interesting, both in the newspaper coverage and in the blog coverage, and in a lot of the emails that we got something like 1,000 emails, a couple of death threats. A lot of people misunderstood what we were saying. There were a variety of narratives, but one of the bifurcations of the narratives, there were a group of people who said this is preposterous and outrageous. How could it possibly be that weight gain is contagious or spreads from person to person? And then another group said, this is absurd, this is obvious. Clearly it's the case that human beings are influenced by the choices and behaviors of other human beings. And to me, it was fascinating to kind of watch the cleavage by which this work was seen and was interpreted. And we'll come back to that a little bit later, especially if you're interested. So this is a slide that shows the network we're going to study. We painstakingly reconstructed this network using archival data that had previously not been used. The Framingham Heart Study, of course, has been around for 60 years, but there were these paper records in the basement that kept track of who is whose neighbor, or where did everyone live, so we were able to reconstruct neighbor ties, who is whose friend, and we were able to reconstruct friendship ties, family members, where did people work, so we were able to see that by dumb luck, different individuals worked at the same place, and then we were able to reconstruct all of these ties for a long period of time. This graphic shows about 12,000 individuals. Every dot is a person. The red perimeter dots are women. This is a convention we'll keep through the rest of the talk today. And the blue perimeter dots are men. The lines can indicate different kinds of relationships, friendship ties, sibling ties, spousal ties, neighbor ties, coworker ties, cousin ties, parent-child ties, and so forth and so on. Here I do not show neighbor or coworker ties, and the kind of tie can be indexed by the color. And then the arrowhead can index the direction of the tie, which is an important detail I'll return to shortly. I might say that Denise is my friend. That's a directed tie. Or if she's my sister, there's no sense in which there's a direction, right? We're siblings to each other. That's a kind of bidirectional tie. And we're interested, as I said, in studying what it means for people's health, that they're embedded in social networks of such complexity more generally. One topic which I'm not going to discuss today, which is itself quite interesting intellectually, is the following. If I were to ask you, where would it be better for you if you lost your job, where would you rather be located? Would you rather be located in the, do we have a pointer, a laser pointer, or no? It's okay. Where would you rather be located? Would you rather be located in the center of the network, or would you rather be located here if you lost your job? Thank you. Where would you rather be located? Center, right? Because if you lose your job, you might be much more likely. Oh, it doesn't work on this screen.
It doesn't work well.
Yeah, on this screen. Yeah, no worries. You'd rather be in the center because you'd be much more likely to know somebody who could help you find a job. And similarly, most of you probably have the sense that it's good to have social support. Being located centrally in the network might confer some advantages to your health. You might be better off being located in the center than in the periphery. Okay? That's a kind of question about your topological position. Where are you located in this topology, in this social fabric? Which I'm actually not going to talk about today. Instead today, I'm going to talk about the issue of how things spread within this network. Once you have this topology, once you define this social fabric, what might flow through it? Because if I were to ask you, where would you rather be in this network if you were trying to avoid catching a lethal epidemic germ, where would you rather be? In the periphery, not attached to anyone, right? So there are different senses in which different things spreading within the network might affect you differently, and your topological position might be important. Now, these people in this network are observed repeatedly across 30 years, and these are the waves at which they're observed, roughly every 4 years. And they come in to be examined by their doctors. There's virtually no loss to follow-up in this network. They're weighed by their doctors. Their height is measured. Their blood pressure and all kinds of other physical examination measures are taken of them. They report how much they smoke. They took these measures of depression, the CESD, a standard measure of depression, and a whole host of other pieces of information were collected about them. And at inception in 1971, the group that I'm going to call our egos, These are the source, the core individuals in the network, and then we're going to look at what happens to them, and they're nested within a larger network of 12,067 people. These egos who entered the study in 1971, upon entry have these attributes. They range in age from 6 to 70. They have an average age of 37. They're about half and half men and women. They have